Hello, good evening, everyone, and welcome to another Facebook Live session. My name is Chipping, and I am your host for tonight's session. Tonight's topic is all about demystifying sarcoma, recognizing the early signs and the treatment available, and especially brought to you by 365 Cancer Prevention Society and our esteemed medical partner, OncoCare Cancer Center. So please like, share, and comment on all of our social media pages so that it can reach out to more people. 365 Cancer Prevention Society was founded in 2003 as a social service agency with IPC status, and we are a full-fledged member of NCSS. Our society's mission is to serve the community through holistic cancer prevention measures. This is accomplished through health and nutrition education, promotion of healthy lifestyle, and our lymphatic detox exercises. We also provide practical and emotional support and care for our members and their family members in their battle against cancer. Please remember that one is never alone in their fight against cancer. We hope that you can join our community in this fight against cancer today. For more information, do visit our official website and follow us on our social media platforms. I believe the handles will be showing up on the screen shortly. So please, thank you very much. So please like, share, and comment on all of our social media handles. And of course, do check out OncoCare Cancer Center's social media pages as well. So before we begin our talk, please kindly note that all information shared at this event by the speaker and 365 Cancer Prevention Society are for general information only and subjected to changes. Do consult your doctor for personalized and detailed medical advice. So, all right, we will start our topic for today, which is demystifying sarcoma. Thank you very much, everyone. So before we begin the talk, I would like to introduce both of our speakers for tonight, Dr. Angela Pang and Dr. Matthew Cheng. Dr. Angela Pang is a senior medical oncologist at OncoCare Cancer Center and also a visiting consultant at the National University Cancer Institute of Singapore. Also with us tonight, we have Dr. Matthew Cheng. Dr. Cheng has special interest in lymph salvage operations for malignant tumors and is Singapore's leading surgeon for children and adult cancer using tumor prosthesis, allograft, and autograft reimplantation, including microvascular and nerve repairs. So let us welcome both of our speakers tonight. Hello, Dr. Cheng, and hello, Dr. Pang.
Hello. Hi, everyone. Thanks for having us tonight, Chiping.
Hello,
No
Chipeng.
problem. Hi, hello. Thank you so much for joining us. So without further ado, I will pass the time now to Dr. Pang, who will begin her sharing. Dr. Pang, please.
Thank you, Chiping. Give me a minute now. Okay. Thank you, everyone, for coming tonight on a Saturday night and spending the evening with us as we try to educate everyone a little bit more about this type of cancers called sarcoma. Hence, the title of our talk is Demystifying Sarcomas. So really, the picture on the left, on the right over here is a picture of Terry Fox. He really is a very famous sarcoma survivor with osteosarc and a very strong advocate as well, which was why when he had recovered from his osteosarcoma, he had founded Terry Fox Run to raise funds for research and also for patients with sarcomas and to increase awareness in this type of rare cancers, which actually unfortunately happens more commonly in young people. So this is just a brief overview of what we're going to be covering tonight. So I'm not going to waste time to go into much about this, and I'll just move on to the next slide. So really, what are sarcomas, right? So they are these really rare type of cancers, making up actually only 1% of all cancers, arising from supportive tissue of the body, i.e. Bone, muscle, fat tissue. And really the diagram over here shows like sarcomas that arises from all the various different organs and different cells in the body. And it's as rare as there's only about 100, slightly over 100 cases per year in Singapore. And it's actually more common, unfortunately, in young people and children compared to adults. And sarcomas represent actually approximately 15% of all childhood cancers. So the difficult part about sarcomas is not just that they are rare. There's also more than 50 different subtypes, or some people who are even more particular say that it's even more than 70 different subtypes of sarcoma currently that we know of. And really it can occur in pretty much any part of the body, but majority of them actually occur in the legs and the arms, so in the extremities. So maybe just a bit of a cheat sheet on, like, what is some of the sarcoma terminology, like, how do we make sense of what type of sarcoma this is. So there are two different groups of sarcomas. So bone sarcomas make up one group, soft tissue sarcomas make up the other. So bone sarcomas, we have osteosarcoma that arises from the bone. Then there is also chondrosarcoma that also actually arises from the bone, but it's more from the bone cartilage. Then you have Ewing sarcoma. Then it's like, Ewing is which part of the body? So the name actually arises from this very esteemed pathologist who, Dr. James Ewing, who actually discovered this type of sarcomas in the very early days of like 1866. This was when he was born. So and then we have soft tissue sarcomas, which is pretty much the rest of the other subtypes of sarcomas. So if they come from skeletal muscle, it's rhabdomyosarcoma. When it comes from smooth muscle, it is leiomyosarcoma over here. And last but not least, if it comes from fat tissues, as you can see in this glistening yellow thing here, it is a liposarcoma. So this diagram is not for us to decipher, but basically is to highlight the fact that there are many, many different types of sarcomas that actually makes it very difficult to manage, and also very difficult to do clinical trials and research in, because they are rare and they are very small in numbers. So what is actually important as probably a take-home message is, like, what are some of the common early sign presentations of sarcomas? Really is swelling of any joint, or swelling that is very visible in any part of your body, like your arm, your leg, your back, your chest, that really suddenly pop up. Or if there's any abnormal swelling of your abdomen, not just for sarcomas, but for other types of cancers as well. If there is a sudden onset of pain in your back, arm, leg, anywhere that does not seem to go away. Of course, we're not saying like if you had gone for a long run and your leg hurts, there is something wrong. It is more like a gnawing pain that does not go away. Or if let's say you have a lump on your leg or your arm that has been there for many years, but suddenly it has increased in size and grown very quickly. So these are all red flags and signs that should bring you to go and see a doctor and seek medical attention earlier. So some people will say, I don't have a family history of sarcomas, but, what are some of the risk factors of sarcomas that we should take note of? So, I mean, the fact is that majority of patients with sarcomas, they do not have any risk factors. But if you do have, then really you need to kind of be aware of it. So some people who have had previous radiation for other types of cancers, they have a slightly increased risk of developing sarcoma in the area where radiation was directed previously. It's a slight increased risk. But if let's say there's something that pops up at that area, it really is important to seek medical attention early. Genetics. So of course, some people who have certain inherited diseases, they may be at high risk of developing sarcomas. Neurofibromatosis type 1, familial adenomatosis polyposis, otherwise known as FAP. People with that are also at increased risk of developing Gardner's syndrome, otherwise known as a syndrome associated with desmoid tumors in the abdomen. And these are a couple of the other genetic syndromes like tuberous sclerosis, Lee-Fraumeni's, etc. And these people are at high risk of developing sarcoma. Some people with immune system abnormalities, like for example, chronic leukemias, or people with HIV, or people with autoimmune diseases such as lupus or psoriasis, they may have a slightly increased risk of developing sarcoma. Some people may have lymphatic drainage blockage, so they get like swelling of the leg because of that, and that's called lymphedema. That is also an increased risk. And some people have been exposed to chemicals either at the workplace or during wartime, like for example Agent Orange, which was basically a nuclear weapon or chemical weapon of some kind that was used during the Vietnam War. And all this would increase the risk of sarcomas, not just sarcomas, but cancers also. So once someone is diagnosed with a sarcoma, some of the investigations that are done would include scans like CT scan, MRI, and PET-CT scan, and most people will require a biopsy. And once all of these are completed, the cancer will be staged according to the findings on the scans and the biopsy. Then they will be brought to discuss at what we call a tumor board, where different doctors will sit down together and discuss about what is the best definitive management plan moving ahead for patients with sarcoma. So then we will cover a bit about the different types of sarcoma. So first we will touch on soft tissue sarcomas. So really, as I mentioned, there are so many types, right? So it's really like a huge mixed bag of different sarcomas under this umbrella called soft tissue sarcomas. Really, what is the main important thing for treatment is really still surgery. Some patients will say, oh, can I not undergo surgery? But unfortunately, the main thing is that surgery is still the main part. You really have to remove the tumor in order to be able to be cured from this type of sarcoma. But in the modern days, when we have better treatment techniques accompanying the surgery, the surgical techniques may be a bit more conservative. That means you may not have to remove your entire limb, and you may still be able to get as good an outcome as someone who undergoes, for example, an amputation. And how good or bad the outcome of the cancer is really depends on a couple of things. The type of sarcoma, the grade of the tumor, how old is this person when he or she gets the cancer, and what is the stage of the cancer. So this is really a very, very thick textbook that is published by the WHO, really for doctors who need to understand sarcoma. You really have to know that there are many, many different types, and this is just to highlight the different subgroups of sarcoma. And the behavior of each type is actually slightly different. There are some that have a very, very low potential of spreading to other places. Some that may be aggressive locally, some may spread to other places very early, and so on. So really, for doctors or people who are treating sarcomas in general, we really have to understand the different types of sarcomas in order to deliver the best type of care for each patient with various types of sarcomas. So this is really just a diagram showing why do some people do a bit better and why do some people do a little bit worse with sarcoma. So some of the important things that we look at will be what is the grade of the tumor, whether it's a high grade, which is a bit more aggressive, or whether it's a low grade and it's less aggressive. How deep is the tumor and what is the size lah. So people with very high grade tumors are more likely to develop disease spreading a bit earlier. Some people with a lower grade but large tumor may not have disease recurrence so early. It may be a little bit later in life. So really, the understanding of how the tumors behave is actually quite important for the doctor following up your care and so on. So really, standard treatment principles for sarcomas for people with early stage cancers is really, as I mentioned, surgery plus minus radiation and plus minus chemotherapy. And the intent is really curative. We hope to cure you. And alongside with the intent to cure you, Dr. Cheng will cover a little bit more about how we would try to preserve your limb and the function of your limb while we, attempt to cure you of your cancer. Right. So then for people who have more advanced cancers like stage 4 cancer, usually treatment is with systemic treatment with medications like chemotherapy or targeted therapy, and the aim is mainly for disease control. So conventional sarcoma treatment has mainly 3 arms: surgery, radiation, plus minus chemotherapy. So this little picture over here with 3 different types. These are like the different types of central line that people put in, like a Porter Cav, a Hickman line, and a PICC line, where chemotherapy can be administered during the process of the treatment, and the lines can be removed subsequently upon completion of treatment. Okay. So then this is really a slide just kind of covering patients who have limb preservation and who have the prosthesis put in order to salvage their limb because this patient has osteosarcoma of the humerus. Right, so really nowadays, limb salvage surgeries are increasingly performed with the help of improvement in our imaging techniques and also accompanying treatment. And really the primary objective in doing cancer surgery is to make sure that the tumor is removed, and also secondarily trying to preserve the limb function so that your quality of life after surgery and such can be as good as possible. So really very much improvement in limb function can really be achieved with better reconstructive techniques. So Dr. Cheng will cover a lot more on all this, and he will show you some examples of some patients who have undergone like procedures like this and have gone on to lead like a very meaningful life with definitely quality of life. So then this is really a slide that shows the more complicated nature of the nature of treatment for people with more advanced cancers in soft tissue. So really it's about understanding what type of soft tissue sarcoma this is to allow us to go on to recommending treatment, whether this type of sarcoma is a chemosensitive type or a non-chemosensitive type, and then we would allocate the treatments accordingly to what we think is more likely to work for your type of sarcoma. So then that basically sums it up for soft tissue sarcoma as a brief overview. Then we will move on to talk about bone sarcomas. So bone sarcomas, the three more common types are Ewing, osteosarcoma, chondrosarcoma, and these are more common in pediatric and young adult age groups. And most patients actually fortunately present with early stage disease, and the treatment intent is for cure. So a very important thing that a lot of doctors who are treating patients with bone sarcomas would have to take note of is some of the unique issues that are faced by patients in this age group. Adolescents and young adult age group is basically classified as 15 to 39 years old. So the issues that they may face would be growth limitations, especially for children who are younger, and then fertility issues, because some treatments that are instituted like radiation or chemotherapy during the treatment process may affect fertility later in life. Image is very, very important to everyone, but particularly for very young people, the acceptance of changes in their image would really be quite a big thing to them. And also, of course, quality of life at the moment during the treatment, as well as long-term quality of life and issues that cancer survivors may face long-term. And that also includes things like risk of cardiac complications, developing second cancers, and also functional limitations. So then I will just cover very briefly about the two different types of bone sarcomas that are more common. So Ewing sarcoma really is more common in teens to people in their early 20s. You will need surgery and chemotherapy. Most people will present with a soft tissue mass from a bone, and they also may have things like fever, anemia, and weight loss. So people who do better from Ewing sarcomas are those who are younger, and those with smaller tumors, and those with tumors that are further away from the center of your body. So the treatment effectively includes chemotherapy, surgery, and chemo. And if let's say the primary tumor is in an area that is not operable, then they get radiation. So treatment can be quite long. It actually spans over approximately about a year, which is the reason why sometimes for young people, this can be very destructive, because they will have to stop school and so on to put things on hold for their treatment. But the chances of cure for people with early stage Ewing sarcoma is actually very good. So definitely we would definitely encourage patients to finish the entire course of treatment. Osteosarcoma is the other type of bone sarcoma, which is the most common primary sarcoma of the bone. And usually it occurs in the second decade of life. Rare, 20 cases per year in Singapore, and most people will present with bone pain, swelling, or a fracture. So treatment for osteosarcoma is quite similar to Ewing sarcoma. In the past, where people used to do surgery only, survival was quite poor, but with the addition of chemotherapy has improved tremendously, perhaps even more than 50 to 70% in the modern era. So treatment is quite similar as per Ewing sarcoma. They require chemo first, surgery, then chemo. And then after that, usually we do not give radiation because it's a relatively a radio resistant tumor. But for example, if let's say the tumor is in an area where we cannot resect, then we may have to give higher dose radiation. So then, moving on to talking a little bit about newer systemic treatment options. Most of our cancer research for new treatments are aimed at treating advanced cancers that are refractory to standard treatment. So novel drugs are usually first aimed at controlling advanced cancer before showing any benefit in early cancer. So sometimes, you may see in like media, like, oh, this is a very advanced, this is like a very new treatment, for example, and such. But just bear in mind that a lot of these experimental new novel drugs are usually developed first for very advanced cancer. So if you do have an early stage cancer, really, you may or may not need this kind of novel treatment from the word go. So the current focus in sarcoma research and clinical trials is to understand the behavior, understand the genetic associations, then we would target the specific treatment approaches and modalities specific for your kind of cancer. And this would implicate on how we choose and the outcomes. So we do have success stories in rare cancers like sarcoma. So this was really in the year 2000 where the first few types of targeted treatment was being discovered. So for this type of sarcoma known as GIST, gastrointestinal stromal tumor, they had discovered this mutation called c-KIT. And really now with this medication called imatinib or Gleevec, it targets this particular mutation and it has really changed the treatment options available for this type of cancer and has really changed the lives of people who have this type of cancer as well. So that aside, so besides GIST, there are also other types of targeted treatments that are used in sarcoma treatment. So I'll just briefly go through. The new medications are like pazopanib, tazemetostat for specific types of sarcomas, and these are the newer medications. Tarulio that is used to treat tenosynovial giant cell tumors of the joints. People with rare sarcomas called PEComa can use this new medication called mTOR inhibitor. And there are very small percentage of patients with certain types of sarcomas that has this mutation called NTRK. They can use the medication that is approved to target this particular mutation. Immunotherapy. So I've had a lot of patients asking me whether immunotherapy can be used for sarcoma. So unfortunately, really, it's not been shown to be beneficial in most types of sarcomas, but in a very, very small percentage of patients with sarcomas, they may have this thing called microsatellite instability or mismatch repair deficiency. And then if that's the case, these patients may be suitable for a particular type of immunotherapy called checkpoint inhibitors. So currently, they are still being developed and studied in clinical trials to see whether they are beneficial for this group of patients. So the clinical trials in sarcoma, as I mentioned, immunotherapy, CAR T cells, and certain targeted oncogene treatment. Clinicaltrials.gov is basically a worldwide website that displays all the different types of clinical trials that are currently available for all kinds of cancers in the world. So then the other common questions that I get from patients is that, oh, can I take this herb? Can I take this supplement? A fairly reliable website is that from the Memorial Sloan Kettering Cancer Center on integrative medicine, where you can actually search the type of supplement that you want to take, provided you know it, the English name. Then you key it in and it will actually tell you whether it will potentially interact with your treatment or not and whether it's safe enough for you to take. But of course, this is not end all. Like, you will still have to bring it back to your doctor and discuss with them to see whether it is safe to take this supplement while you're undergoing your cancer treatment or not. So then really it brings us to what to ask your doctor if you are diagnosed with a sarcoma. So common questions that you should ask would be, what's my diagnosis? What's my type of sarcoma? What is the stage? What are some of the treatment options? Whether it's conventional or clinical trial? What are the benefits of treatment? What can I get from this treatment? And what are side effects? And of course, in this day and age, what is the cost of my treatment? Is this going to be covered by insurance or my MediSave, MediShield? And what not to do while on treatment so that you can be safe and get through your treatment as smoothly as possible. So these are some very common questions that you should ask your doctor, while you are, if let's say you cannot think of what to ask, these are some of the very common things that you should at least ask so that you can have a better understanding of your own condition. So then these are some of the reliable online sources of information where these are like reliable international cancer society websites so that you can get more additional information about your type of cancer and such lah. So then last but not least, in Singapore we do have a sarcoma support group. These are really like fellow sarcoma survivors and patients who strive to support one another during their cancer journey, and really to talk about it with someone else who has gone through the same kind of treatment or difficulties as you is really quite helpful to most people who are going through this difficult period in their life. So then with this, I thank you for listening to my talk, and I'll be very happy to answer more questions during the Q&A later. So with this, I will hand the session back to Dr. Matthew Cheng and let him carry on with the second part of the talk tonight. Matthew, over to you.
Thank you, Angela. Just to recap, sarcomas are malignant tumors, and they originate from what we call mesenchymal cells. And most of you would be familiar with cancers, or we call them carcinomas, because that's the bulk of the tumors that we encounter. And carcinomas come from the epidermal or skin, outer skin, or endodermal, the inner skin, that means in your intestinal linings, for example. And they're actually depicted in this picture like a multiplying cells. Usually the lymphatics are at this level at the dermis and they spread by lymph nodes, but the difference in sarcomas is that they originate down here in the deeper tissues, or we call them mesodermal, the in-between tissues, and they tend to spread by blood. So they go to lungs and to the bones. They're also different from carcinomas, your usual cancers, because they are more uncommon, and because they lack surface clues, they are deep inside. They spread hematogenously, which means by the blood, and they would be found in distant areas like in your bones and in your lungs. Generally less amenable to radiotherapy and chemotherapy, which the more common carcinomas are. There are some exceptions. Ewing sarcoma is radio and chemosensitive, and osteosarcoma is chemosensitive. So these modalities are used in these sarcomas, but the mainstay of sarcoma is surgery. You should consult your doctor because he will do the relevant examinations and imaging. You should never ignore a lump. You should not massage a lump or introduce needles into a lump in case it's a malignant tumor and you would be seeding it further or spreading it. You should not have marginal or intralesional excisions, meaning that just removing the tumor is not good enough. You need to remove with a clear margin. So we routinely do wide excisions for sarcomas. It's been a long time catchphrase of limb salvage in these tumors because historically sarcomas are deadly and they have been treated with amputations. However, in the last 20, 30 years, limb salvage is, I would say, the norm. So it's no longer, I think, a catchphrase. It's just the usual treatment, and majority of my patients have limb salvage. However, there will be a fraction of patients who do not qualify for limb salvage, because if limb salvage does not save the patient's life, then that's the incorrect choice. I'll illustrate some do's and don'ts in soft tissues and bone sarcomas, starting with this case where you can see an MRI is required to see the extensive involvement of this tumor, which is deep inside. The reason why this patient has all this bruising is because she went for a massage. So do not massage, because you would be increasing the area of tumor spread. This results in requiring a larger area of tissue removal and loss. Another case who went for cupping as well as bloodletting, and all this insult to this area of the thigh where the tumor was results in these MRI findings. So here is the tumor, and you can see that it's now extended quite a distance away from the original site, extending upwards, extending downwards. Do not go for treatments that would increase the spread of your tumor, because it would result in a larger area of tissue loss. Going on to some examples of bone sarcomas, with the advent of implants which can replace the removed bone. So this is an osteosarcoma which was removed, and here we have the implant. And with technology now, it's usual to have a new knee joint, and therefore limb salvage is a common procedure. After that surgery,
can you please walk?
This is what the patient can do, because the bone has been
Straighten your leg as much
replaced.
as you can, your right leg. Lift it up and down, straighten the leg as straight as you can. Maybe your legs as you like. Okay, bend as much as you can.
We have the ability to reattach the tendons as well to aid in the knee function. As you can see, she has lost this part of the bone due to the osteosarcoma, but she's doing well. You could replace other bones, in this case, the distal thigh bone, and have
It's 4
excellent
years post
function.
surgery. Can you walk, please? Yep, and then turn around and walk back and sit down. Okay, I want to see maximum bending of the knee. Okay, and I want to see straighten of the knee. Okay, straight. Okay, that's good. And that looks like it's 4 years post.
Although the norm, 90% of my cases are salvaged, we should not ignore cases where amputations are necessary. Amputation should not be seen as a death sentence. Actually, I believe that having completely removed the tumor, if necessary with an amputation, you survive and you start living. The worst amputation in the lower limb that you can think of is when a patient has tumor in the pelvis, such that you need to remove half the pelvis. This is called a hemipelvectomy. So this half of the pelvis has been removed. But here we have the patient going back to school, living her life, walking around with crutches, and also swimming. So amputations are not a death sentence. Curing a patient leads to more life for living. I want to touch quickly on alternate salvages. That's not the full limb salvage, neither is it a full amputation, but we can use uninvolved parts to increase functional outcomes, and I'll show you two examples. due to the removal of the tumor, rather than amputating the hand, this index finger, which is here, has been used to reconstruct the thumb, and having good margins for the tumor, there is no more recurrence. And the patient is many years out, and there is reasonable function. This young girl has osteosarcoma of the tibia, and due to certain reasons, she requires an amputation. But rather than having an amputation above her knee, she had an amputation above her knee, but her ankle, which was uninvolved, has been reattached to simulate a new knee for her. Intentionally, she is kept long because this other leg will grow with time. And again, she's back to school. This is what the new knee would look like.
Number one, strong.
So
and the toes are pushing.
it can extend.
Number one is quite strong. I like it. Number two.
It can flex.
Number two, after that, can be improved. So we're going to stretch this way. Number three.
External rotate.
Number four.
And internal rotate.
Number five. Use this buttock muscle and you're pushing downward. Okay, I want to see.
And this is a video of her riding a bicycle. As you can see, her knee with a prosthetic leg. So the knee, it's now functional. And this is what I term as still as a partial salvage. So I want to show you these cases. Many of my patients have survived sarcoma with proper treatment. So it's not the end, there is hope, and there's more to life to enjoy. Thank you. Over to Chiping and Angela.
Thank you, Dr. Che. Nice to see you back again. And welcome back, Dr. Angela Pang. All right, thank you both for that very informative sharing. I hope that everyone who is watching has learned more about sarcoma, which is really a rare form of cancer. So once again, thank you both for your sharing, and we shall proceed to our Q&A segment. So to the audience who are watching our Facebook live session now, please keep the questions coming. We will do our best to answer all of your questions. All right. So for the first question that we have today, perhaps I could pose it to Dr. Matthew. What can be mistaken for sarcoma? If you would enlighten us, please.
So many lumps have different causes. Because of the rarity of sarcoma, one should always be careful. It's very hard to tell what the lump could be. So it's best if you have a lump, if it's increasing in size, if it's large, you should seek medical opinion. Your doctor can examine you and do scans to assess whether it's likely to be something dangerous or it's something that is benign. So go and see a doctor. It can be painful. It can also be not painful. So in fact, I recently saw a friend's mother who had a small lump, just 3 centimeters, just underneath the skin, but it turned out to be a sarcoma. Now, not to scare everyone, chances of that happening is actually low. But should you be the one, you need to seek treatment and seek treatment early.
All right, thank you, Dr. Ching. So I guess as what you shared, please, if you notice that you have a lump, do get it checked out because you never know if it could be a serious case or it could be just not a serious case. Thank you so much. All right, for our second question, perhaps I could ask Dr. Angela. Can sarcoma be detected by blood tests or rather by tumor markers?
Oh, yeah. So this is really a very common question that we do get. So as you can imagine, it's really a rare type of cancer. So at the current moment, there are no real tumor markers, nor are there readily available screening tests that can pick up sarcoma. So we've seen many a patient who have had otherwise health screening done, but they've also noticed a lump that they did not mention to the health screening doctors that have appeared. So really the assurance of health screening is good, but the fact is that if you do notice something that is abnormal and unusual, you yourself are probably like the best person to be able to tell. So if there's anything abnormal in that sense, be it a lump, tummy swelling, or something that is unusual, a pain that wasn't there and just really came on and didn't go away, these are really some red flags for you to seek medical attention. I mean, if it really is nothing and your doctor tells you so after working it up, then that is great. But certainly don't miss things lah. So because there's no like health screening methods for sarcomas because it's quite rare lah. Yeah.
All right, thank you, Dr. Angela.
No
All
problem.
right, for our next question, I think I can pose this to Dr. Matthew. Is limb salvage possible for all types of sarcoma? Could you please advise us?
So that's a tricky answer because the answer can be yes, but whether it's the correct treatment. So you can limb salvage everyone, but is it the correct treatment for everyone? So generally, 90% of my cases have limb salvage. The remaining 10% of sarcomas is not because you cannot do limb salvage, it's because you would not get adequate margins. So you do not salvage the limb without adequate margins. The advance of orthopedics so far is that we have replacements for the tissue that we removed, particularly joints and bones. So therefore, salvage becomes possible when it wasn't possible in the past. But that's still on the premise that you remove all the cancer completely.
All right. Thank you, Dr. Ching. We have our first question from our audience. So from B. Kwan, perhaps I can pose this to Dr. Angela.
Sure.
Could you share with us what is LMS? I believe it's leiomyosarcoma.
Myosarcoma.
Yeah,
Yes.
thank you. So perhaps you could share with us a few lines on what that is.
Sure. So, I mean, in short, basically what the name means is it is a type of sarcoma that arises from smooth muscle. So the most common areas that we see leiomyosarcomas arising from is the uterus in women, as well as in the abdominal cavity at the behind section of the abdominal cavity, which is what we call retroperitoneal leiomyosarcomas. Some rarer ones, some people have leiomyosarcomas of the large veins in our body, otherwise known as the inferior vena cava, and some people have very rare ones, maybe of the lymph. So treatment, fairly standard. You really still would need to undergo surgery to remove the tumors generally. And if the tumors have fairly higher risk characteristics and such, sometimes in certain instances, some patients may require radiation. And whether there is a role for chemotherapy or not, it also remains to be discussed with the doctors depending on the type of tumor, the grade of the tumor, how big it is, and whether it has been removed in completion. Then in people with more advanced leiomyosarcomas, the treatment really would then involve mainly using chemotherapy. If we go into the finer details of the type of chemotherapy, it will be a whole lecture on its own. So then really, in more advanced leiomyosarcomas, it's really going to be primarily chemotherapy to control the cancer. So I hope that answers the question about a bit about leiomyosarcoma as it is.
Thank you, Angela. Dr. Angela, thank you so much.
No
All right,
problem.
we have a second question from another member of the public. I think this is from Doris. Perhaps I could pose this question to Dr. Matthew. What will trigger a relapse of bone sarcoma? Could you answer this question, please?
Trigger.
Do you think that's a question that you could answer?
So when we say relapse, it means tumor coming back in the same area, not the same as metastatic tumor, meaning that it comes back in another place. So if you have a local relapse, let's put it again. Relapse meaning where? I'll answer it both as local relapse, and if you think that something that spread elsewhere to the lungs is a relapse, okay, then we call it metastatic disease. Most patients don't have metastatic disease that I have from the onset, so I won't consider it as relapse back to the lungs. But if you find something in the lungs, then that would be considered metastatic disease. I believe the question may mean local recurrence. So local recurrence usually means there is inadequate surgery or removal of the tumor. With adequate removal of the tumor, complete removal of the tumor, there should be no local recurrence. When you get local recurrence, it means that inadequate removal of the tumor has occurred. So what risks local tumor recurrence? Inadequate removal.
All right. Thank you, Dr. Ching. We have a second question. I think this is a follow-up question. Maybe I can post this to Dr. Matthew. Can sarcoma survivors go for TCM years later after their surgery?
So what I mentioned about acupuncture or tuina, nothing against TCM. Those are for not to be done when you have a tumor in your limb. Any action on the part would enable or increase the risk of spread locally as well as to other parts of the body. As for when you are a normal person or disease-free, then it makes that is not a problem. Hope I'm answering
Thank
the
you.
question.
I think you did. Thank you, Dr. Ching. So if a person has a lump, would you advise that he or she does not actually go through with TCM, or rather just get medical advice first? Would that be the case?
Definitely. The reason is because that lump may turn out to be something malignant. So until you know what it is, you should not disturb that lump.
All right.
I
Thank you,
know
Dr. Matthew.
traditionally that we do massages if you think you have some injury near your joints, etc. But an injury is not the same as a lump or a tumor. If you're not sure, then I would still recommend that you see the doctor before you do any massage to the area.
All right. Thank you, Dr. Matthew. We have a question from Caroline. Perhaps I can ask this to Dr. Angela. Given its rarity and many subtypes, what are the chances of misdiagnosing one type of sarcoma for another? I'm not too sure what this means, but this person has quoted example of ESS versus ULMS.
So I guess I think what it means is, okay, really sarcomas are quite rare kind of cancer. So I think this particular member of the audience, Caroline, is probably asking about uterine kind of sarcomas. So uterine sarcomas, there are a few types. Endometrial stromal sarcoma is ESS. ULMS is otherwise known as uterine leiomyosarcomas. So uterine sarcomas is a spectrum. People with ESS, generally, they are very low grade, very slow growing. They are hormone sensitive. The ones that are very high grade are right at the other end of the spectrum, which is leiomyosarcoma. As you can imagine, there are some similarities because they are all grouped under the same umbrella of uterine sarcoma. The likelihood of misdiagnosing is actually not very high, but sometimes there are certain features of it as the tumors in the uterus may have been there for some time and they change in terms of behavior. So for a doctor to be able to make the diagnosis correctly, the tumor has to be removed and then the pathologist will look at it under the microscope very, very carefully to make sure that there is no misdiagnosis. So the likelihood of making the wrong diagnosis is actually not very high, but there are some types of uterine sarcoma that may have features that are confusing. That means they may have features that are in between. So that's why there are some cases that sometimes the diagnosis can be actually very difficult to make. But I would say majority of them, the diagnosis is actually accurate because most of our pathologists who are the doctors who look at the microscope at the cell, they are specially trained in this area to look at sarcomas. So the likelihood of misdiagnosis is actually not high. Yeah, I hope that
Okay.
answers the question.
Yeah, I think you definitely did answer. Thank you so much for explaining that in so much detail. For the
Yeah.
next question, perhaps I can ask this to Dr. Matthew. What can one expect after a limb salvage procedure? For example, after they wake up, will there be any pain or any side effects? Could you elaborate?
After any surgery, you would need the wound to heal and there will be pain. Your
Mm,
doctor would be giving you medicine for the pain.
mm,
So, with proper medication, and if the situation allows or requires, uh, the doctor will tell you what movements you can do. Many limb salvage patients of mine actually walk the next day, but some of
mm,
them are not supposed to walk depending on the situation. So each case is different depending on what needs to be done and what has been reconstructed.
mm. All right. Thank you, Dr. Matthew. We have one last question for Dr. Angela. So,
Mm.
with the new advances in treatment of sarcoma, like what is the life expectancy improvement in late stage sarcoma patients?
Oh, okay, that's a very good question, but it's also a fairly layered question. So let's just say sarcoma, there are different types. There are some types that are the slower growing and the more what we
Mm,
call indolent. That means the tumor cells don't grow very fast. So some of these patients with late stage sarcoma with fairly indolent and slow growing behavior, they can go on to survive for even as long as 5 years or more. But these are certain subtypes. But the general group of sarcomas, with all the advances in treatment that we have and such, unfortunately, being diagnosed with a late stage sarcoma is, of course, not a great scenario. The median survival for most people with as much treatment as we can give is approximately about 2 years with the current advances that we have. But there are some fortunate ones, there are some fortunate patients who do better because even though they are diagnosed with advanced disease, but they are able to undergo treatment that works well for them. So really, with subsequent advances in medical therapies and such that we hope that all of these will generally improve. And we also hope that there will be more support for research in rare cancers like sarcomas so that we can improve the outcomes in general for everybody.
All right. Thank you, Dr. Angela, for answering
Welcome.
that question. All right, I believe we have come to the end of today's session. So huge thank you to everyone who have posed the questions, and we hope that we have answered your questions as best as we can. And of course, huge appreciation to both of our speakers for tonight, Dr. Angela Pang and Dr. Matthew Cheng, for both of our sharings and for answering everybody's questions. So I think it's time now for you guys to take your leave. So thank you very much, and I will see you again. Bye bye.
Thank you, Chipane. Thank you,
Thank
everyone.
you,
Good night.
Chipin.
All right, so at this point, we would like to appreciate everyone for joining this session. So if you could please leave us your feedback by scanning the QR code on the screen right now. We will just leave this here for perhaps 10 to 20 seconds for everyone. We would greatly appreciate if you could leave us your feedback on today's session. All right, so for our next Facebook Live session, it will actually be happening on the 20th of August, and it is about stomach cancer. So if you would like to join us for this session, the timing is still the same at 8:30 p.m., and you can find us on our Facebook page. So once again, do like and share our social media pages. I believe the handles are up on screen now. Yes, thank you very much. So like and share our Facebook pages for 365 Cancer Prevention Society. We have Facebook, Instagram, and we also have a Telegram group as well if you'd like to join us. And also do not forget to check out OncoCare Cancer Center's social media pages as well. So once again, thank you everyone for joining us tonight, and also a huge thank you to all of our medical partners for their sharing tonight. And I hope to see you all at the next session. So do take care, stay safe, and goodbye. See you guys.